Hello and welcome to the University of Michigan Labor and Delivery Unit. My name is Patricia Greco, and I'm one of the maternal fetal medicine fellows. And one of the things that I will be talking to you about today is pregnancy and hypertension. Let me just pull up my presentation. Okay, so we're just going to go ahead and get started. In terms of some background information, hypertensive disease in pregnancy complicates about 5 to 10% of all pregnancies. There are increased rates of prematurity in pregnancies complicated by hypertensive diseases. And also we know that cardiovascular conditions are a leading cause of maternal mortality and morbidity in the United States. In terms of the rate of hypertensive disorders, you can see here that over the years, there's been more and more pregnancies complicated by hypertensive disorders at the time of delivery, as well as chronic hypertension. And so how do women present with this complication? So frequently there'll be a combination of symptoms, but usually there is at least one of these: a sudden headache that will not go away, swelling of the hands or face, seeing spots or changes in eyesight, pain in the upper abdomen or shoulder, nausea and vomiting, sudden weight gain, difficulty breathing, and then generally a feeling of just unwellness. And so there's this nice little here schematic that you can see that goes over what preeclampsia is and the risks to you and your baby. And we'll go into detail about some of these a little bit more over the coming slides. So how big of a problem is it? In 2010, it affected about 3.8% of all pregnancies, and the cost for preeclampsia or hypertensive disease in pregnancy was estimated to be about 2.18 billion. So it's a pretty significant issue. It's the leading cause of pregnancy-related deaths overall. And you can see here, so cardiovascular conditions, so this encompasses preeclampsia and other hypertensive diseases. You can see here that 13.8% of pregnancy-related deaths are related to cardiovascular conditions. And that preeclampsia and eclampsia in particular are about 8.3%. So can we change these outcomes? There was a study that was recently published in 2019 that looked at the number of maternal deaths over a period of 5 years, and this was in the state of California. And 54 of those 333 deaths were related to preeclampsia or eclampsia, so 16%. 96% of those deaths were thought to be potentially preventable. 62% were considered to be very preventable. And is actually 40% of those women who died were considered to be low risk for complications at the start of their pregnancy. So this is a pretty significant finding and really highlights the importance of this disease and understanding it and knowing more about it. So we're going to step back now and take a little bit of an overview of all the hypertensive disorders in pregnancy, just starting with knowing that there is chronic hypertension, severe chronic hypertension. So that's hypertension diagnosed or present before pregnancy. So we're going to step back and take a look here at the all the hypertensive disorders in pregnancy. And so this is a nice table from the ACOG practice bulletin that just demonstrates chronic hypertension all the way to superimposed preeclampsia. And so first we'll start with the definition of chronic hypertension. So chronic hypertension is elevated blood pressure that's diagnosed and or treated prior to pregnancy or diagnosed in early pregnancy, and generally that's considered to be less than 20 weeks. The American Heart Association has this nice table here that tells you the category of blood pressure and what is considered normal, elevated, or high. So in general, the normal blood pressure range is a systolic less than 120 with a diastolic less than 80. Something that's considered to be elevated is 120 to 129 for systolic and then less than 80 for diastolic. Once you get to a systolic pressure of greater than 130, that's actually considered to be stage 1 hypertension. And diastolic would be once it gets above 80. And then stage 2 is when your systolic is greater than 140 and diastolic is greater than 90. And then a hypertensive crisis is anything that's a blood pressure greater than 180 systolic or higher than 120 diastolic. So in pregnancy, we can get chronic hypertension that's with superimposed preeclampsia. And superimposed preeclampsia is not always easy to diagnose and is often a diagnosis of exclusion. So it's a little bit of a tricky diagnosis to make. What we'll often see is a sudden increase in blood pressure, a sudden increase in the amount of protein in the urine, a sudden increase in symptoms that we talked about earlier. So the swelling, headache, right upper quadrant pain, feeling unwell, and then a new thrombocytopenia or newly elevated liver enzymes or an elevated uric acid. And so we look for a bunch of different things to make that diagnosis. So moving on to our next definition that I want to cover is gestational hypertension. And so gestational hypertension is when we have a blood pressure greater than 140/90 for the first time after mid-pregnancy, which again is considered to be 20 weeks gestation, but in whom proteinuria is not identified. The blood pressure returns to normal by 12 weeks postpartum and can be accompanied by signs and symptoms of preeclampsia about half the time. And it's a real challenge for diagnosis in those women who didn't have health care prior to pregnancy, and especially for those women who present for their initial prenatal care in late pregnancy. So preeclampsia, what is that? That is a combination of gestational hypertension, so what I just mentioned in terms of the blood pressure parameters, as well as end organ damage. So for a diagnosis of preeclampsia, you have to have a blood pressure that's greater than 140 systolic or greater than or equal to 90 diastolic on 2 occasions, at least 4 hours apart after 20 weeks of gestation in someone who previously had a normal blood pressure. And you have to have proteinuria. And so that's considered to be greater than equal to 300 milligrams per 24-hour urine collection, or a protein creatinine ratio greater than or equal to 0.3. But if there is absence of proteinuria, you can have the new onset hypertension with any of the following things, including thrombocytopenia, so platelet count less than 100,000, renal insufficiency, so any serum creatinine that's greater than 1.1 or doubling of the patient's baseline serum creatinine in the absence of other renal disease, and impaired liver function. So this would be considered to be twice of the normal concentration for that patient, or pulmonary edema or cerebral or visual symptoms. The severe complications of preeclampsia include HELP syndrome. So HELP is when you have hemolysis, elevated liver enzymes, low platelets, and it is considered to be a form of preeclampsia with severe features. And blood pressures can be normal or minimally elevated. The other severe complication of preeclampsia is eclampsia. So that would be a new onset of grand mal seizure activity or unexplained coma during pregnancy or the postpartum period. And it's considered, again, to be a complication or form of preeclampsia with severe features. And I just want to go back to this previous slide. So what I talked about was the diagnosis of preeclampsia. So initially preeclampsia without severe features. And so that would be this blood pressure range. Once you get a blood pressure range that's greater than 160 systolic or greater than or equal to 110 diastolic, that would be considered preeclampsia with severe features. And so we talked about HELP and eclampsia. Another severe complication of preeclampsia is stroke. And so elevated blood pressure during pregnancy is the leading cause of stroke in pregnant women or women who have recently given birth. The symptoms for stroke can typically occur suddenly and it can include any of the following things. So there can be numbness or weakness in the face, arm, or leg, especially if it's on one side of the body. Confusion, difficulty speaking, difficulty understanding others, difficulty with vision, difficulty with walking, dizziness, loss of balance, loss of coordination, and a sudden severe headache with no known cause. Another severe complication can be something called PRESS syndrome, which is posterior reversible encephalopathy syndrome. It's a clinical radiological syndrome characterized by headaches, seizures, altered mental status, and visual loss. Altered consciousness may vary from mild confusion or agitation to coma. Other symptoms include nausea, vomiting, and brainstem deficits. Seizures and status epilepticus can also be seen. On imaging, what we'll see is some white matter vasogenic edema affecting the posterior occipital and parietal lobes of the brain predominantly. And this is associated with eclampsia or preeclampsia. So what does all of this mean for women? It plays a role in both maternal well-being and fetal well-being because it can affect your gestational age of delivery. And so what happens when this diagnosis is made prior to 24 weeks? Do we deliver or do we continue the pregnancy? And the actual recommendation, once a mom has a diagnosis of preeclampsia, is actually to end the pregnancy. What happens when a mom is greater than 24 weeks or less than 34 weeks pregnant? Again, the question is, do we deliver or do we continue the pregnancy? And I think the first decision is to make when you're at this gestational age is whether it is safer for mom and baby to remain pregnant or to be delivered. The second decision is whether the mom needs to be monitored in the hospital or can be monitored at home. These decisions are well outlined by ACOG. And preeclampsia with onset prior to 34 weeks is most often severe and should be managed in a facility with appropriate resources for management of serious maternal and neonatal complications. Because ambulatory management at home is an option only for those women with gestational hypertension or preeclampsia without severe features. However, if they are managed at home, there should be frequent fetal and maternal evaluation. And so these are all the things that would be severe complications of preeclampsia and reasons to be monitored in the hospital. So uncontrolled hypertension, persistent headaches, abdominal pain, visual disturbances, stroke, MI, HELLP syndrome, renal dysfunction, pulmonary edema, eclampsia, placental abruption, abnormal fetal tracing, and fetal death. And so this is house or home, or house or hospital. And hospital, as I mentioned, is the preference. So what about if a mom is between 34 and 37 weeks pregnant? The first decision to make is whether it is safer for mom and baby to remain pregnant or to be delivered. And so we have to look at, again, what is going on with the mom. Is there severe hypertension, thrombocytopenia, liver dysfunction, renal dysfunction, headaches, etc.? All the things that we talked about. And the second decision is to make whether or not to monitor mom at home or in the hospital. Again, this decision is well outlined by ACOG. And moms can be at home unless they have severe features or diagnosis of severe preeclampsia, because once you're greater than 34 weeks, the recommendation is for delivery. If the preeclampsia is without severe features, then they can be at home, and the mom needs to have twice weekly antenatal testing and blood pressure checks, as well as weekly labs. What happens once you're greater than 37 weeks? Do we deliver or do we stay pregnant? And for any hypertensive diagnosis in pregnancy, the recommendation is delivery. So based on a large multi-center randomized control trial called the HIPPOTAT trial, with delivery, there was a 29% reduction in maternal morbidity when moms had diagnosis of hypertensive disease in pregnancy. There was no difference in neonatal outcomes. So what different treatment options are there? We have hypertensive medications that can be oral, they can be emergently oral or IV. We also have IV magnesium that's given to prevent seizures around the time of delivery and postpartum. So we'll talk about magnesium sulfate first. This is a medication that's administered IV, renally cleared. You have a loading dose of 4 to 6 grams, which can be done safely regardless of maternal renal function. Maternal infusion rates should be altered though if there's decreased glomerular filtration rates. And so if your creatinine is greater than 1 or your urine output is less than 30 mLs per hour over 4 hours. Magnesium sulfate can have a small but significant effect on the fetal heart rate pattern. So what we'll sometimes see on the monitoring is a change in the beat to beat variability. So it'll look a little bit flatter. There are known protective effects of magnesium against the development of CNS disability in premature infants. And that's why for prematurity, we recommend magnesium less than 32 weeks. Although for preeclampsia, it's at any point with delivery if there are severe features present. Magnesium sulfate is contraindicated in patients with myasthenia gravis, patients who have severe renal failure, any patient who has myocardial damage or ischemia or heart block. And so eclamptic convulsions are almost always prevented by plasma magnesium levels between 4 and 7. Patellar reflexes disappear when the plasma magnesium level reaches 10 to 12. And so this is a sign to serve to warn of impending magnesium toxicity. At 12 or higher, there is risk for respiratory paralysis and respiratory arrest can occur. And so this is why it's really important to do magnesium checks with exam. And if you see a change in reflexes or that should be a sign to check the magnesium level and ensure that you do not need to pause the medication. For treatment, if your magnesium is super therapeutic, you use calcium gluconate or calcium chloride, which is 1 gram IV, and you discontinue the magnesium sulfate, and this will usually reverse the mild to moderate respiratory depression. If it's severe, you may need to use continued doses of calcium because it's a short-acting medication. As for antihypertensives, there is a whole bunch of medications that we use for management of the blood pressures themselves. Listed here, we have labetalol, hydralazine, and nifedipine. These are our most common medications. Dosages vary depending upon, the goal blood pressure, upon the presentation, upon, what the patient's initial blood pressure is. I think the most important things to highlight here are when you would avoid certain medications. For example, labetalol, you avoid in women with asthma, any pre-existing myocardial disease, heart block, bradycardia, any decompensated cardiac function. So postpartum medications, we'll sometimes use different medications in addition to those blood pressure medications we just quickly looked at. So Lasix or furosemide is something that we tend to avoid before delivery because it can compromise placental perfusion. And what it does is it will redistribute intravascular volume, which is most often already reduced in severe preeclampsia. And therefore, before delivery, diuretics are not used to lower blood pressure. And the only reason to use these medications before delivery is to treat pulmonary edema. But postpartum, we can use it for management of blood pressures and pulmonary edema. This can be given orally or IV. And then enalapril is an ACE inhibitor that's contraindicated during pregnancy, but safe in breastfeeding and can provide renal protection, especially for those women who have a comorbidity of diabetes with their hypertensive disease in pregnancy. And so what happens next? So we know that, as I mentioned early on, that hypertensive disease in pregnancy is kind of a window to cardiovascular health for women in the future. And so one of the things that's an emerging information, as I mentioned, is this hypertensive disorders of pregnancy being a risk factor for cardiovascular disease in the future. And so the American Heart Association recommends a yearly follow-up of blood pressure, lipid profile, and blood glucose concentration for women who had any hypertensive disease in pregnancy. So in summary, chronic hypertension and hypertensive disorders of pregnancy are common and increasing. Hypertensive disorders of pregnancy can lead to significant maternal morbidity and mortality. Supporting access to healthcare before and after pregnancy is essential, and supporting women's understanding of these disorders is important. And then finally, I just wanted to highlight, listen to these women. So if they're saying that there's something just not right or they're feeling unwell, that could easily be the first symptom of hypertensive disease in pregnancy. Thank you.